So thank you so very much for joining us. My name is Michelle. I am the Research Grants Director at WCHRI. I am going to ask Jessica if she could please get us going.
Hi, everyone. My name is Jessica Haight, and I am a PhD candidate in the School of Public Health at the University of Alberta. And I'm really pleased to serve as the session moderator today. On behalf of WCHRI, thank you so much, everyone, for tuning in and taking the time to attend the session. I'm just going to share my screen here. Are you able to see my screen okay? I want to begin in a good way by acknowledging that this conversation is taking place on Treaty 6 territory, the traditional lands of the Cree, Dene, Nakota Sioux, Saulteaux, and Blackfoot nations, and the homeland of the Métis. We honor the profound wisdom, knowledge, and experiences of the Indigenous peoples who have been stewards of this land since time immemorial, and whose teachings continue to illuminate the path forward for our sacred responsibilities as health researchers now and for generations to come. As someone with a settler background, I feel grateful to live and work on these lands. Also, as a researcher, I work with the First Nations community of Musqueam, which has taught me the importance of doing research in a good way that empowers people and communities. I would also like to thank WCHRI's funders, the Stollery Children's Hospital Foundation and the Alberta Women's Health Foundation for making this research cluster possible. WCHRI is actively seeking to build this research cluster, so please reach out to WCHRI to join the cluster, nominate any collaborators or networks who are doing relevant research. The email is in the chat, and you can reach out to Michelle, who will stay in the session to answer any questions you have about participating in this research cluster. This session will be recorded and posted to the WCHRI website. WCHRI will send out a link to the recording. And please allow about 24 hours until the recording is uploaded. So we are looking forward to sharing our research with you, and we encourage all your questions after each presentation. And so I'll start by introducing our presenters. So I'm pleased to introduce Rebecca Gokiert, Augustine Batau, and Kemi Amodu. Rebecca is a professor in the School of Public Health, Associate Director of the Community University Partnership for the Study of Children, Youth, and Families, and the Director of the Evaluation Capacity Network, which bridges community university evaluation gaps, serving as a hub for students, researchers, government, and community organizations to share and access evaluation expertise, resources, and educational opportunities. She is a scientist clinician who has devoted her career to interdisciplinary inquiry in early childhood development, partnership and collaboration, community-based research, and measurement and evaluation contexts. Rebecca is also a registered psychologist and specializes in assessment and intervention in school-based settings. Augustine is a PhD candidate in the Faculty of Education and is also a researcher at the Community University Partnership and Evaluation Capacity Network, as well as the Alberta Innovates Impact Action Lab. Augustine's research focuses on refugee health and children's health, and he has expertise in program evaluation, measurement evaluation, and community-engaged research. Kemi is an assistant professor in nursing at the University of Alberta with a passion for improving healthcare access for equity-deserving groups, especially women. With expertise in global public health and analyzing maternal healthcare delivery systems in developing countries, her research journey has evolved to focus on understanding how these women navigate the challenges of accessing perinatal care. Her research also includes ethnographic studies with affected women living in refugee camps in Nigeria, particularly exploring how they navigate reproductive health challenges amidst displacement. She has international experience working in healthcare and collaborates with NGOs and government ministries of health in developing countries like Nigeria, addressing issues related to gender, settlement of displaced persons, and equity in healthcare access. And so now I'd like to turn it over to Rebecca to take the floor.
Thank you so much, Jessica. Just while Augustine is getting our slide deck up and going, I appreciate the warm welcome and acknowledging the land where I'm also joining from today, Treaty 6 territory. I thought I should also give a little tidbit more about Augustine, although you provided such a lovely introduction, Jessica. Augustine is an international PhD student from Ghana. He's studying in measurement, evaluation, and data science. Not often do we find evaluation folks that love this work, so I'm very excited to be working with Augustine. And he brings to his work on refugee child health many, many years of experience running very large-scale evaluations on behalf of UNICEF and the UN. So I feel honored to be co-presenting with him today. I'd also like to acknowledge some of my colleagues and students at the U of A that support the work that we're going to be sharing with you today, and specifically the executive director. Maybe Astrid, if you want to give a wave. She's the executive director of the New Canadians Health Centre, and Astrid lives and breathes the center. So if you have very specific detailed questions, I encourage you to use the chat function, and Astrid, I'm sure, would be happy to answer. And Astrid, we also encourage you to step in if you've got anything to add as we go through our presentation today. So we're going to be talking at a fairly high level about using evaluation to strengthen a principle-based refugee community health center in Edmonton, Alberta, and some associated research projects. We're not going to be going into any great detail. We don't have a ton of time today, and you're probably most interested in hearing from Kemi because she is really talking about healthy pregnancies in this cluster. But we want to talk about refugee health and access to healthcare within the context of Alberta. So just moving to the second slide there, Augustine. I really want to start our time together just providing a bit of context for why a refugee health center is critically important. So for those of you that don't work in the refugee settlement sector, Canada resettled over 51,000 refugees in 2022 alone, and this number is just steadily increasing. A significant number of refugees are pregnant and parenting women, young families, and children. And we know refugees face very complex health and social needs, and they experience significant barriers and access to healthcare. We also know that to experience successful integration into Canadian society, access to healthcare is essential. It's essential for everybody. So we'll just move to the next slide. So until 2021, which is quite recent, Edmonton was one of the only major cities in Canada without a dedicated refugee health center. This is important in Edmonton because we're a main receiving site for refugees. In 2023, we received, as an example, 5 chartered flights, and they're transporting hundreds of asylum seekers. And essentially, they're all showing up with very complex health and social needs and need a safe space where they can receive care. And unfortunately, our current healthcare system was not and is still really struggling to meet these complex physical, emotional, mental health, and social needs of the refugee population. We also know that without access to a holistic model of healthcare, refugees' health and well-being can decline further and negatively impact their quality of life and integration into the community. So to respond to this need, now we'll go to the next slide, Augustine, thank you. The New Canadians Health Centre, NCHC, you'll hear me use that acronym, opened its doors in 2021. It's a community health center that provides integrated healthcare through a coordinated multidisciplinary team of medical staff, allied community members, and professionals really coming together to wrap around government-assisted refugees. It's co-located as a clinic in the basement of an apartment building in downtown Edmonton. And when government-assisted refugees arrive in Edmonton, some of them are settled at this apartment complex, and they're supported by Catholic Social Services, which is a key settlement organization in Edmonton. The NCHC, as I mentioned, serves government-assisted refugees, but the goal is, with more sustainable funding, they would like to provide support to privately sponsored refugees and also refugee claimants. So there were some real key advocates that kind of recognized this gap in healthcare access and support for refugees, and they really supported the NCHC to open up its doors. So this included a medical doctor, a settlement worker, a professor of nursing, some key organizational leaders from settlement agencies in our city. And so they reached out to my center at the time, the CUP, you heard about CUP, really to support them in kind of walking alongside and studying the development of the NCHC. They saw this as a unique model of healthcare delivery, and they wanted to make sure that they were documenting and learning as they were going along to sort of support the development of the center. So at the time, we developed a research and evaluation working group. We started meeting regularly to discuss how we might build out an evaluation framework that would align with the principles and values of the NCHC, and it could be useful for supporting the implementation and ongoing learning as it opened its doors. So we'll go to the next slide, Augustine. So I've mentioned principles and values. The NCHC is guided by 5 main principles. So as you can see in the figure there on the right, so it's a welcoming and inclusive center. It's community owned. It adopts a social model of health. They act collaboratively across everybody that works at the NCHC and the clients they serve, and it creates a supportive learning environment. All of the principles, as you can see in the center and the heart, are underpinned by the promotion of social justice, equity, and inclusion. And essentially, the NCHC seeks to reduce inequalities and increase access to healthcare opportunities and conditions conducive to health and well-being for all. We're going to stay there, actually. Sorry, Augustine. I'll stay on that slide. I'm just going to share a little bit more about the principles that guide the NCHC, and it really begins with the perspective that health is a fundamental right of every human being. So we believe at the center that health cannot be realized without social justice, equity, and inclusion. And therefore, these principles must really guide all of the work that's done at the NCHC, the clinical practice to the wraparound services to the research and evaluation. And we understand that health is impacted by broader social determinants, and so we adhere to a social model of health. And central to this approach is our commitment to foster community ownership and decision-making so that refugees see the NCHC as their home, a place that's welcoming and inclusive. So throughout all of this, we honor a supportive learning community that builds capacity within and also beyond the NCHC as we act collaboratively in providing an exemplary system of refugee healthcare and a bridge to long-term support. So now you can move to the next one, Augustine. So in terms of services that are offered at the NCHC, they do go beyond addressing just clients, and I'm using the term clients, that's what's used at the NCHC versus patients' healthcare needs. The center does provide medical services through physicians, nurses, nurse practitioners, such as diagnosis, treatment plans, preventative screening, referrals to specialists, and immunization, and they're serving all refugees birth to any age that kind of walks through the door if they're a government-assisted refugee. It also offers mental health support such as counseling services, and beyond healthcare, settlement counselors, cultural brokers, social workers are providing settlement and housing support and really aiding clients in navigating the Canadian health and social systems, which are incredibly challenging for GARs, but all Albertans, I can speak to that. It's difficult to navigate our systems. So we'll just go to the next slide, Augustine. So in terms of navigating the healthcare system, the NCHC, as I mentioned, currently serves government-assisted refugees, and that's for a period of up to 2 years. So the goal is at that time that they transition to a primary care physician in the community. So the goal is to equip clients with the ability to navigate the healthcare and social systems on their own. They have the education, the knowledge, the abilities. However, as you can imagine, this comes with its own set of challenges, specifically in our province, because many Albertans are struggling to find a primary care physician. And for these clients, this is of course further challenged because they come with significant pre-migration experiences that continue to influence their healthcare needs and ultimately their health outcomes. So next slide. As I mentioned earlier, early in the days of the NCHC opening its doors, a key partnership formed between our research center at the U of A and the NCHC, and the goal was really to build research and evaluation capacity and infrastructure as the NCHC was sort of getting underway and implementing and operating. So to accomplish this, we worked really closely with key interest holders at the NCHC. So we work very closely with refugees with lived experience, with the NCHC staff and all the allied professionals that wrap services around clients. We have a research and evaluation committee, and there's also the NCHC board of directors. And together we strive to create a healthier and more welcoming environment for our new Canadians, ensuring they find the care and support they need to thrive in their new home. And as NCHC employs principles, we talked a lot about principles, approach to its delivery of healthcare, we're really walking alongside to assess the integration and the internalization of these principles and values in its operations. So a key guiding committee I mentioned is a research and evaluation committee, which essentially kind of got going out of that smaller research and evaluation working group. And you can see that the committee has many key functions. Notable among them is, of course, co-creating an evaluation that aligns with the center's principles and values, as well as liaising with the Circle of Lived Experience and the center's board of directors. And that's really to ensure that research and evaluation activities are aligned with the community's priorities. We've also been working on creating a data and research access protocol for anybody that wants to conduct research in partnership with the NCHC. And this has actually been this has been really important because there's all kinds of medical students, academics, other graduate students that are sort of knocking on the door saying, hey, I'd like to find out what's going on here. I'd like to partner in research. So this is really important. We've also spent a good deal of time in the last few years applying for funding, because if any of you are academics or researchers on the call, you know that research takes considerable capacity and also funding. So we've had some success with that, and we'll keep trying. The committee itself comprises members of the community, academic members from many faculties and disciplines across our campus, staff from the NCHC, and medical undergraduate and graduate students. So really they are kind of have the heartbeat and the pulse of what's going on at the center, and so they can really support any research and evaluation activities. So we'll go to the next slide, Augustine. So my job is leading a team to walk alongside with the Research and Evaluation Committee to essentially assess whether the core principles of the NCHC are upheld and how they influence refugees' experience toward their preferred health and well-being, as well as how they enhance equity, social inclusion, and strengths. So I keep talking about principles. We're using a principle-focused evaluation, which is really a novel evaluative approach for those of you who aren't kind of living and breathing the evaluation world. And it was developed by Michael Quinn-Patton in 2018. And this approach was developed because he really recognized that principle-driven projects and programs similar to the NCHC, they really differ from goals-driven programs. And they require, of course, different evaluation approaches. The NCHC goes beyond just being a program or an intervention because it's really complex, it's dynamic, it's quite unpredictable sometimes from day to day. I'm sure Astrid can attest to this. And using traditional goal-oriented evaluation won't really capture the complexity of the NCHC as well as the impacts. Could even lead to sort of misleading or even really kind of irrelevant or extraneous results. Our evaluation is also developmental because the NCHC, although it has a model of care, is really learning as it goes. So our job is to walk alongside and provide real-time evaluative information and feedback that can inform and support continued development of the NCHC, and also kind of growing and enhancing and advocating for different kind of specialized services. And then, of course, to ensure the relevance and sustainability, we really do prioritize, and I mentioned that already, with the board of directors, Circle of Lived Experience, and the many folks that sit on the Research and Evaluation Committee, really recognizing their contributions to the evaluation's development, implementation, and also the use. So I will wrap up here pretty quick and hand it over to Augustine. But I just wanted to share, and again, I'm not going into results or findings at this point, but for a principle-focused evaluation, we're really focusing on multiple methods and gathering different sources of evidence. So we engage the clients at the NCHC through focus groups and interviews. This can be storyboarding, journey mapping as different methodologies that we use. We also engage the staff at the NCHC quite regularly. And this is through focus groups, through interviews, more leaning towards interviews because they're incredibly busy. So getting folks together as a group is challenging. But we do that through existing meetings. So some of the staff reflective practice. And then a big significant source of data comes from our analysis of the electronic medical records, chart reviews, document analysis, and then also process mapping of the NCHCs, really like their operational processes and their workflows. Of course, if you're interested in learning more about those nuances and details, we'd be happy to chat with you after the session, and we'll provide our emails. So just moving forward, again, as I mentioned, we're kind of giving you the high notes, and Augustine's going to give you some high notes as well on some more strategic research initiatives, which are being conducted by, colleagues of ours on campus, some of our students in terms of thesis projects. And this has really been a way for us to leverage grant funding, to bring student capacity and community partnerships to move some of the priorities of the NCHC forward. So I'll pass it over to you, Augustine.
Okay,
you're
sorry, I was muted. Yeah. Thank you, Rebecca, for sharing the background about the NCHC. And as Rebecca mentioned, I'm going to walk you through some of the research that we've been doing at the center. As you can imagine, there are various knowledge gaps when it comes to refugee healthcare access in Canada, in Edmonton, Alberta in particular. I'm going to walk you through some of the things that we've been doing in terms of research and evaluation. Due to the scope of this session, I will highlight 3 of our main projects. The first study was conducted by one of our past students that focused on the needs and expectations, and as well as recommendations for Afghan refugee women at the center regarding the healthcare they receive. This study was a narrative inquiry that engaged service providers at the center through 2 focus group discussions to understand their perspective and experiences in serving Afghan community at the center. Additionally, 2 semi-structured interviews were conducted with Afghan women at the center to explore their pre- and post-migration experiences, as well as their lived experiences receiving healthcare in Canada. The interviews were conducted with the help of interpreters, and I'll tell you why we did that as I move through the other studies. But the outcome of the study truly highlighted the need for a tailored, gender-focused, culturally safe healthcare for this population. Our second study, our project, it's a WCHRI-funded project. It's through the WCHRI implementation grant, and focuses on refugee children's experiences accessing care at the healthcare service at the center. It explores the principles. It explores how the principle-based model that Rebecca talked about better support health outcomes for refugee children. Over the summer, we engaged service providers that included nurse practitioners, physicians, and the executive director at the center. We also engaged refugee youth and parents and caregivers of children 0 to 18 who receive service at the center. Within the qualitative component of the study, we conducted 9 semi-structured interviews with service providers to understand their perspectives in delivering service to refugee children. We also conducted 21 interviews with parents and caregivers to also understand their perspective and experiences in receiving care. As I mentioned, we also conducted 1 focus group with youth clients at the center to also understand the services they receive. As Rebecca mentioned, we're not going to talk about results here, but if you're interested, you can reach out to us and we'll share what we have so far. As part of the next steps, we'll be conducting qualitative components of the study, and that will involve assessing the EMR, identifying and examining demographic characteristics, as well as the health needs and outcomes of refugee children served at the center. We'll also translate and transcribe qualitative data that we have, conduct summative analysis, and present the findings to the Research and Evaluation Committee. Our third study, which more links to the topic that we're discussing today, is looking at exploring barriers and facilitators that refugee women experience when accessing maternal health care service at the center. This study involves a scoping review and a qualitative descriptive study. The scoping review identified barriers and facilitators that are impacting access to maternal health care services for women in Canada. Preliminary results from the scoping review shows that there are language barriers, cultural and religious differences, navigating the healthcare system as a challenge, and there are also logistical challenges. For the qualitative descriptive study, the aim is to understand perspective and lived experience of women, clients at the center who are assessing maternal health centers, assessing maternal health care at the center. We plan to conduct 10 to 12 semi-structured interviews, but so far we've been able to conduct 5. We'll be successful with 5, and analysis are underway. Before I end with my slides, I want to walk you through some of the lessons that we've learned whilst we're working in partnership with the center conducting research and evaluation activities. Some of these learnings have been possible because we've adapted to the needs of our population that we are studying. And so one of the key things I want to highlight is that for you to do any study at the center, there's a need for a data access protocol, especially if you're going to access data from the electronic medical records. And my advice is that you start early, as it's a long process and it takes a significant amount of time. For conducting interviews with at-risk population, such as our various population that we've been engaging in, it requires a lot of preparation. And some of this preparation includes constantly assuring participants of the confidentiality of the information they share with you as a researcher and autonomy of the participants. You also have to prepare yourself physically and emotionally in engaging this population, as well as their safety of the participants. We always advise you that you always recognize the power dynamics between you as a researcher and the population that you're going to engage in, which is your participants. It requires a significant amount of time for you to gain their trust and to build rapport. And so I'll urge you again, start early. As I mentioned, with all our interviews or our research activities, we engage translators because we want to engage participants in their native language. And so we would advise you to recruit and train translators who speak participants' native language, and also account for cultural and religious differences between you, the researcher, and the participant. For example, how you engage them. And this means knowing your population. I'll give you a typical example. In our study over the summer, we recruited male translators and interviewers. But as you know, engaging women requires that they express themselves, but they felt discomfort because of the partners. They came to this interview with their partners, and hence they were not able to share their experiences authentically and unfiltered. We were able to successfully conduct 5 interviews with Afghan women because we had a female interviewer and translator who helped us to do this. We'll continue recruiting and engaging women for this study. And at this point, I will tell you that we're engaging with Kemi, who's going to be our next presenter, to help us to share more information about the Her Maternal Health Project and how we're partnering with her to continue our data collection. At this point, I'll hand over to Rebecca for her to close out.
Thanks so much, Augustine. So thank you for joining and listening. I think you're eager to hear from Kemi, who will get focused right on the realizing healthy pregnancies. But again, if you are curious to learn more, want to chat with us, we appreciate the questions and comments in the chat. Please just reach out, and Augustine and my emails are there, and I also put the NCHC link in the chat as well. Thank you.
Thank you so much, Rebecca and Augustine, for the great presentation. So I'm going to get right into it. So the focus of my presentation centers on the New Canadians Health Centre and the Refugee Women's Health Research that we were funded for by WCHRI. Before I proceed, I should introduce my research assistant, Karen Pengen, who will be presenting first. Karen will provide a background review of the scoping work that we did around the perinatal health access for ethnically diverse women in Canada. Karen is a recent Bachelor of Arts graduate from the University of Alberta in psychology and sociology with experiences in mental health advocacy, as she held leadership positions in various community organizations. She has also contributed to psychological research through Dr. Kyle Nash's Social Neuroscience Laboratory in EEG volunteering. Currently, she works with the Royal Alexandra Hospital Foundation, which holds access to healthcare for equity-deserving groups in high esteem. Her contributions have been essential to our research, and this review will highlight how it serves as the foundation for our ongoing research with refugee women in the NCHC. So I'll pass it over to Karen.
Thank you, Kemi, for that bio, and thank you all for your warm welcome. I would also like to thank Dr. Gokiert and Mr. Botway for your presentation. I think we all found it very helpful, and we're eager to see the results of your investigations and your discussions. Thank you as well to the WCHRI Pregnancy Research Cluster for having us today to present our findings on perinatal health care. Can everyone see my screen at this point?
Looks great, Karen.
Thank you. All right. So I'll get us started here with a quick overview of today's presentation. So we'll start off with a little bit more context about who we are and what we do, as well as going over our scoping review, which I will head. Kemi will then talk about our perinatal health access proposal, our next study, and the next steps on top of that study. So starting off with our introduction, given that our research is conducted within Beaver Hills House, we would like to thank WCHRI for their land acknowledgement, as well as add that through our research and overall pursuit of equitable healthcare structures, we continue in our efforts in solidarity by presenting the systematic barriers to health systems that affects all marginalized communities. Moving on with a quick overview of our scoping review. In our research on the perinatal health of ethnically diverse populations, we began to aim to assess the relationship between ethnic minority women in Canada and their perinatal health and healthcare. Through their experiences and knowledge, we aimed to answer the question, what is the existing state of healthcare structure for Canadian women of ethnic minorities through health outcomes, healthcare experiences, existing research, and clinical interventions? To answer this question, we analyzed 45 studies in a systematic literature review. For additional context, these 45 studies were spread throughout various provinces in Canada, with some studies focusing on multiple provinces, such as healthcare alliance groups, or mentioning Canada as a whole. These various studies also defined ethnicity and race through different parameters, so whether through continental groupings such as African or Asian, nation-specific ethnicities, or immigrant status. Given our team's research interests in immigrant populations as well as our own lived experiences, we chose to focus on non-white and non-Aboriginal groups for this scoping review. As a disclaimer, in our paper and in this presentation, we cite the sources according to the wording of the original articles and how they present ethnicity. As you can see in the slide, there are very many ways of defining ethnicity within this study. While many of the results of the articles reviewed highlighted the disparities of disease or disorder prevalence and the specific processes of support structures, today we will cover the specific disparities and perceptions of healthcare system as a whole. What we mean by the healthcare system is the combination of both the physical healthcare structure, so hospitals, healthcare centers, community supports, as well as the research aspect of healthcare, which guides the creation of clinical tools and priorities in disease research. We must first acknowledge why investigating this relationship is pertinent in the first place. And some of the studies that we have reviewed, for example, older generations of immigrants would advise second generation or younger immigrant mothers to partake in traditional cultural medicine. In some cases, this advice would replace or overwrite the medical advice provided by doctors and other healthcare professionals. However, the advice and guidance of healthcare practitioners are still valued by women of minority ethnicities. So in some cases, academics note that there is a problem of accessing cultural knowledge that would have otherwise supplemented the treatment of minority populations. In many cases, in our scoping review, researchers call for more projects with community engagement. This would then supplement current understanding of healthcare. So far, we've alluded to a larger healthcare structure that is not immune to discrimination through exclusion or lack of inclusive practices. This is supported by the multiple articles that go over specific disparities in clinical and research tools and the specific gaps of knowledge within the healthcare system. Today, we will also take some time to look at the specific calls of action that many of these authors speak to, and how Dr. Amodu and our research team draws inspiration from these calls to actions in the upcoming project with the New Canadians Health Centre. In our analysis, we have found two trends that point to disparities in healthcare. With relation to disparities concerning ethnic minority populations, 13 out of the 45 studies that we've examined discuss gaps in healthcare with direct relation or mention of race or ethnicity. 8 out of the 45 articles that we've covered in this review discussed gaps in research with the relation again to race and ethnicity. So these are excluding calls to actions that are general focuses on the disease itself. So for example, general research on gestational diabetes. When we say discuss gaps in healthcare, discuss gaps in research, this is again in relation to race and ethnicity. The primary call to action for 13 articles in this literature review focus on disparities within healthcare itself. These issues are presented on screen, which can range from lack of ethnic-specific screening tools, so birth charts, GDM screening tools, depression or anxiety tools. They also note educational tools and communication, that knowledge translation, that appeal to women at risk for issues such as type 2 diabetes, B12 concentrations as a result of particular lifestyles, as well as treatments such as general pregnancy diet management that does not take into account culturally sensitive or different practices. If we take a closer look at this first point, the use of inappropriate tools can lead to concerns and allocation of resources in cases where it may not be necessary, such as in labels for large for or small for gestational age based on Canadian-centered birth charts, as opposed to nation of origin-centered birth charts. As with every study, there is room for discussion on the next steps of research. In 8 cases, authors point to gaps in research that can greatly benefit women of vulnerable minority ethnicities when addressed. So these can include a few different ways of addressing such. The evaluation of research of a particular disease towards general non-white, non-Aboriginal populations, such as in the cases of maternal cytomegalovirus, maternal blood pressure, or identifying the ideal lifestyle interventions for these non-white ethnicities. Or it can also compose of a direct focus on how specific minority populations interact with or have this relation with a previously existing disease. So this can include B12 levels for South Asian women after identifying that there may be a risk for this specific population. So as well as gestational diabetes, postpartum depression, general perinatal cultural health customs. So these are more context-based. I also note the Urundwanayo study at the bottom. It is a great example of a paper that discusses focusing on a phenomenon that is in itself is not well researched and has significant effect on minority ethnicities. So in this case, it would be the antenatal mental health outcomes of immigrant women. So this examination is on the granular scale within research or healthcare clinical tools. So these specific gaps is not the only evidence of disparity within the healthcare system. Larger areas of growth within the healthcare system are reflected in the observations of various authors. In a few instances where within our literature review, authors point to structural issues within healthcare, discrimination, limitation on available resources, such as culturally competent providers and programs available for those seeking that support. However, many articles also state the importance of developing health systems and practices that are in themselves culturally sensitive. So this can be influenced by the education of future healthcare practitioners, the development of how we understand cultural differences within healthcare itself. So this is seen through Urundwanayo's suggestion of the transnational theory to understand cultural differences in shaping knowledge. So these are all important because they can influence access to healthcare in general and are stated to be a factor in this limited access to healthcare, perinatal healthcare. Finally, the articles discuss the potential for developing these gaps through increased social support. So the onus of this of disparities within healthcare system is not only limited to the healthcare ethnicity, healthcare industry, and ethnicity itself is not the only factor. I would like to highlight an article by Rakhsin et al. In 2021. In their findings, they note that government intervention on financial strain can assist in supporting women. And we also see how these intersecting factors affect perinatal healthcare experiences and access. So for example, in Morisaki and Zoliniak et al.'s papers, they mention how intersectional approaches can affect perinatal healthcare access by looking at factors such as social, economic status, as well as education. Within the articles mentioned today and acting as a pertinent theme of this literature review, we can recognize the potential for greater support of women of color. Dr. Amodu's portfolio of research examines healthcare access through the lens of many marginalized groups. Some of her work examines the access of various types of healthcare, whether mental, physical, reproductive health. They take into account the vulnerable populations of refugees or displaced persons or migrants. The next project we will show today, as I hand this presentation over to Dr. Amodu, comprises of a mixed method study that examines the perspectives of refugee women and their healthcare providers in Alberta. With that, I'll pass the next portion of this presentation to Dr. Amodu as she speaks to her upcoming research project with NCHC.
Thank you so much, Karen. That was an excellent presentation. Yeah, and I'm sure you you provided a platform for more questions around women's health in Canada.
Thank you, Kemi.
Yes, so I am going to be excitedly presenting the study that we're working on with the New Canadians Health Centre. We're looking at perinatal health outcomes, needs, and experiences of refugee women in Alberta who access services at the New Canadians Health Centre. As Rebecca alluded to already, the NCHC is a fairly new initiative offering integrated care for refugee women and their families for up to 2 years. Now, this is important because women often face incredible challenges, everything from trauma, violence, and health complications when they come to Canada. Karen, can we move on to the next slide, please? So our aim today basically is to describe the study that we're working on. It's really to understand how well the NCHC healthcare model meets the unique needs of women, and to use this knowledge to propose ways that we can improve refugee healthcare in Alberta, especially around perinatal health care access. So about the NCHC. The NCHC opened its doors in 2021. It's pretty special because it is the first dedicated refugee healthcare center in the city, and it offers care specifically designed for government-assisted refugees. Now, the center's approach is very holistic. In addition to healthcare, they provide services in conjunction with organizations like Catholic Social Services, the CSS, to address broader issues like housing, employment, things that are crucial for families' well-being. So there has been quite a number of research, as Augustine mentioned, that's been done around refugees arriving to the NCHC for care. But this study is quite unique in the sense that we'll be focusing on refugee women specifically, and we'll be looking to really map out their sort of process of accessing care within that setting. Now, why is the study important? The study is important because it fills a gap in our understanding of how refugee women access perinatal healthcare in Alberta. We know that they face unique challenges when they come to receive care based off of their backgrounds, and we're hoping to use the data that we collect from this research to create a model that is sort of an example for other clinics across Canada to sort of examine and to see how this might show what works and doesn't work. We will be able to share these insights with healthcare providers and policymakers to make real changes. Now, ultimately, our goal is to help improve healthcare delivery for refugee women, not just at NCHC, but in other parts of the healthcare system as well. Now, one of the reasons in particular that we chose to do this work is because refugee women deal with things like language barriers, financial challenges, and even cultural misunderstandings from healthcare providers. And especially now with the pressures post-COVID-19 on the healthcare system, there are increased barriers to having access to healthcare for them. And it'll be interesting to see what the results of this work is. Some of the findings from preliminary reviews show that a lot of research have been done in hospital services, in terms of hospital services for refugee women, but not around community-based healthcare access for this population. So what were questions that we wanted to tackle through this research? First, on the quantitative side, we're gathering data on the demographics, service utilization, and health outcomes for refugee women at the NCHC. We want to know who's using the services and what their health journeys look like. Now, qualitatively, we will dive into the experiences of women themselves, as well as healthcare providers, and how we want to know, for example, how they feel about the prenatal and postnatal care being offered, and if the resources, services, and referrals really work for them. And finally, our third objective is to work together with women, healthcare providers to develop practical recommendations, and then potentially map out some of the ways that we can improve sort of the process of transition to long-term care services. Now, moving on to our team. Our team for this project is truly interdisciplinary. We bring together expertise from various fields, including public health, medicine, and psychology. The diversity in our team allows us to tackle the complex issues refugee women face during perinatal health access experiences. So we have had Astrid by our side from the beginning of the conceptualization of the project until now. She provides ongoing guidance on the development of the project and implementation. And we also have Dr. Molly Wallen-Brown, who is a family physician and a medical director at the NCHC, who has deep insights into the refugee health landscape in Edmonton, and she will be helping guide our clinical research. We also work with the Catholic Social Services, a very key community partner who will help us connect with the refugee population, especially in the aspects of settlement and integration. Now, we also should recognize the research and about, I think we need to stay on the previous slide. So I also should mention the Research and Evaluations Committee at the NCHC. This committee oversees research activities at the clinic and provides crucial support for recruitment, particularly in engaging patients and clinical staff for studies like ours. So the REC has been a part of this research, and they will be instrumental in helping us plan patient engagement strategies and advise on recruitment strategies as well. So we're planning to hold more frequent meetings with them, hopefully starting in November. Now to our theory. Yeah, Karen, we can move on now. Thank you. So intersectionality was chosen for this study because it is important that we are able to see that health inequities are not just caused by one factor, like gender or race alone, for example. Instead, these elements interact with other social categories like class, immigration status, or trauma history, which many refugee women have experienced. And these factors combine to create unique vulnerabilities for refugee women. So refugee women have complex interlocking challenges, and they're exposed to, for example, incidences like war, violence, traumatic pregnancies, even before arrival to Canada. And it's really important to also recognize that they do experience sometimes geographical limitations in accessing healthcare facilities. And all of these factors, including lacking support systems, have crucial impacts on their experiences during pregnancy and childbirth. So by looking at how race, gender, trauma history, and socioeconomic factors might intersect, we can better understand the barriers refugee women face in receiving perinatal health care. I think we can move on to our methods now for time. So essentially for this research, we're going to use a community-based mixed method approach, which means we'll be using both quantitative and qualitative strategies to collect data. And we'll also have a co-design team, which essentially comprises of the research and evaluations committee members, some patient partners that have lived experiences who will be supporting us with recruitment and data collection. So basically, our co-design team includes a diverse group of people. We are going to have academics, program leads, and healthcare providers who work directly with refugee populations. So they're not just involved in planning, they're also engaged throughout the research process and very instrumental in decisions about recruitment, interview locations, and strategies for ensuring effective language interpretation. And these teams' involvement ensures that our approach stays grounded in the real needs of refugee women and are culturally appropriate. Now, for those wondering, we are also very close to receiving the ethics approval from the University of Alberta Research Ethics Board, and that's like a really big milestone for the project. So our phase 1 for the research is the quantitative data collection phase. We will be analyzing de-identified medical records information about refugee women who received care between 2021 and 2023. This EMR data will give us comprehensive information on prenatal history, utilization of services, and obstetrical outcomes. And importantly, all this data will be de-identified for privacy. Now, we'll use this data to look at trends and relationships between demographic profiles and healthcare outcomes. And this will give us sort of like a glance at the patterns of healthcare access and utilization. Now, for our phase 2, which is qualitative data collection component, we will be asking women themselves to participate in qualitative interviews, where we'll be learning about their lived experiences, as well as health service provider perspectives. Now, we'll be conducting semi-structured interviews in the preferred language of participants, and we'll be able to capture not just the words, but also the cultural nuances around their healthcare experiences. Now, we'll also be running focus groups with health service providers to give us the other side of the story in terms of challenges that providers face when delivering care and how the NCHC's model works from their own perspective. Now to phase 3, which is the final phase of the research, is that we are hoping to be able to design or co-design sort of a plan of action for future research based on everything that we've learned together with refugee women, healthcare providers, and stakeholders. We'll be creating evidence-based tools and strategies to improve perinatal healthcare at the NCHC and beyond. So we'll be providing a comprehensive report, which will be presented to decision makers and government representatives, advocating for policy changes that can improve healthcare for refugee women across Canada. In terms of expanding our research beyond this work, we do, I think that should be on perhaps the next steps, Karen, is where we're at now. Is an important part of this research is to say that we are also concurrently conducting a review around transfer of care, so transition of care from settlement agency-oriented programs to community primary care centers. And we're seeing that from the research, there is not a lot of work around perinatal health care for refugee women in general. Most of the research that we find, either they are lumping immigrant women with refugee women as a group, and essentially it's very difficult to identify perinatal health care as a concept on its own, and how that's you know, a special sort of area to really focus on. Also, one of the things that we found from the preliminary review that we're doing right now is that a lot of the work really focuses around mental health of refugees who come to Canada and not on the reproductive health piece of their experiences. Essentially, we've also found anecdotal reports that some physicians in Canada have turned away refugee patients due to complications with the interim federal health program coverage system that they use to cover refugees, essentially because of the cumbersome process of processing that and lack of knowledge in some cases. So one of the things that we hope to do is to examine in the future sort of the experiences of refugee women in the long term, in terms of integrating within the primary healthcare landscape, and for example, accessing family physicians and obstetric and gynecologists, obstetrician and gynecologists, I mean, and family physicians. So Dr. Sujuta Chandra, who's on the team, will be instrumental in helping us to collaborate and to find partnerships within the primary healthcare landscape. And that would be the end of my presentation. Thank you.
Thank you so much. Fantastic presentations and really exciting research. We have a couple minutes for questions now. I saw there were lots of questions already in the chat, but if anyone has any more questions, you can either raise your hand, come on your mic, or type a question in the chat.
Yeah, not to put you on the spot, Astrid, but you just heard me talk a lot about our work together, and then Kemi talking about future work, but I don't know if there was anything you wanted to add at this time.
No, I don't think so. I think you guys did a beautiful job describing everything. It is always certainly a passion for me to hear other people speaking so highly and with so much passion about refugees and the New Canadians Health Center. So I just want to say thank you. And thank you all for attending today.
There's been lots of chatter with Elizabeth. Elizabeth, thank you for your questions. We could probably sit and have a coffee for more than an hour talking about, actually, Augustine really led that work, and just getting 21 interviews conducted. I'm sure many of you do work in this space and know how challenging that is. And that was like a major, it took, I think, all summer and all hands on deck, and Astrid connecting us to many real trusted kind of volunteers and folks at the center around recruitment, but also even just to conduct the interviews and kind of invite people into that space. We went into folks' homes as well. But certainly it was not without its challenges. So 21 interviews was like, it was as if we collected maybe like 100 interviews, maybe, Augustine, would you say? Felt like that.
Yeah, I mean, it took a lot of time in finding the people, the participants, recruitment. It took so much time and required a lot of strategy to get them. So, anybody going to that space? And of course, we wouldn't have been able to do all this without the able support of Astrid and her team at the center. A big shout out to Nada who helped us, because there were instances where we had to conduct interview at the staff kitchen, and she was like, "No, you can't do this here. I'll find you a space," and she always does. So.
Great work done. Thank you.
Wonderful. Thank you, everyone. I added the New Canadians Health Centre website in the chat again for anyone who's interested in taking a look.
I have a question for Kemi and Karen, and it's a selfish question. Is your scoping review published yet, or is it under review? Is it in a shape that you're able to share it with others, or even, you know, kind of the key references or the key pieces of literature that you extracted?
Yeah, so actually I already sent, I think, yes, I did send it out for publication with a journal. I think it was about a month ago. But it's yeah, it's still under review.
Okay. So to be continued. Hopefully it'll be. Okay, I don't know if we have any questions. Maybe we were so thorough in our presentations.
Well, thank you, everyone. Thank you so much to our presenters today. That was fantastic. Again, if you're interested in participating in a future research cluster, you can always reach out to Michelle, who is in the call. And I think that is it for today. So thank you so much to everyone for joining.